recording now. All right, so this is now the second meeting of the ISCET nystagmus guideline development subcommittee. I'd like to thank Matt for his direction so far. What we'll first do is go through some apologies. So I got apologies from Mervyn Thomas and I got apologies from Omar this morning, but he has sent through some feedback already. Now, what we're going to do is go through the previous minutes. Has everyone here read the previous minutes and do they agree with the content of them? Okay, I'm seeing general nodding and agreement in there, but to briefly summarize, and Matt can correct me if I've missed anything. The last meeting, there was a decision made to develop, I think, a system-based guideline versus a disorder-based guideline for eye tracking. So we went and discussed the pros and cons for each, but basically we thought it'd be best to model it on something like the ISCET, where it's based on different systems as opposed to specific condition, but that we would use nystagmus as kind of like the kind of questions that would come up clinically. And the purpose of the guideline is to allow non-expert clinicians, the ability to use tracking in a practical, more simple setting as opposed to what we would normally do in a research setting. The idea of labeling it as a guideline is so that we're not actually prescribing what people should do or how people should diagnose things. So it's not something that they have to absolutely do. There should be some flexibility in it, but we can set a minimum kind of standard and possibly the ideal standards. I think the other thing we did by the end of that committee was meeting was to elect or start the process of electing a chair and vice chair. And as you know, I've been elected chair and my vice chair, Rebecca, is also on the call. So that just means that we're able to manage these meetings going forwards. If one of us is busy in clinic, the other should hopefully be able to continue doing these meetings. So have I missed out on anything there, Matt? I think that's basically.
I think that was pretty complete. The only thing I would just say is that the focus with ISCET is on the kind of technical aspects rather than the diagnosis side. So we're looking we're looking at the procedures that would be done, and of course it would be up to the clinician to decide when to actually administer all of these tests.
So then from following on from that meeting, the other thing we had to do was come up with a list of kind of the questions that clinicians would be asking and where tracking might come in. So we'll look at that later in the meeting. But I thought before we go any further forwards, that we'd make sure that we are happy with the terms of reference, so that we know what we're aiming to do and what our role in it, and also authorship criteria. So Rebecca and I did draft some just as a starting point. So I don't know if everyone here has had a chance to read them, but we could have a quick look through them and see if there's anything that needs to be added. And that way we're very clear on what we need to do going forwards and what everyone needs to do to be considered an author on the publications going forwards. Okay. So what I'll try and do is share. I think I have the guide. So let's go with the drafts authorship criteria. If I get that open and drag that across, hopefully. That's authorship and the terms of reference. Right, so can everyone see the terms of reference? I think I've got them up on the screen. So we can just briefly scroll through them to see. So we thought we put in the purpose, so just to keep us on track. So we want to develop evidence-based, consensus-driven clinical guidelines for the assessment and management of nystagmus using eye tracking technologies. Although we're going to try and be condition agnostic, we just need something to get us started on writing a guideline. So objectives, so we'll review current practices and literature on eye tracking and nystagmus, try to develop standardized guidelines for clinical use of eye tracking and nystagmus, promote international collaboration, harmonization of clinical protocols. We can change terminology if it's not completely appropriate here. And to ensure guidelines are inclusive, accessible, and adaptable across diverse healthcare settings. And the membership, so this is the subgroup, everyone on the call, and also those people who could not be on the call, and should consist of international experts in ophthalmology, neurology, vision science, clinical research, and eye tracking technology. All members are appointed based on expertise, geographical representation, and commitment to the subgroup's objectives. And then the chairs will lead the subgroup and facilitate meetings and decision-making processes. So we've got roles and responsibilities, so standard stuff. So the chairs will lead and coordinate the activities. We'll try to ensure inclusive and transparent decision-making and represent the subgroup to the broader society. And the members' responsibilities are to actively participate in meetings and discussions, contribute expertise and review relevant materials, and assist in drafting and reviewing the guideline documents. Next, decision-making will be consensus. So we might not be able to reach consensus online, but we'll make sure that everyone offline also has a say, and then we might reach consensus afterwards. If we cannot immediately achieve consensus, we'll have further discussion and evidence review until we can reach an agreement. And minority viewpoints will be documented where relevant. So meetings will be held virtually or in person, I think most likely virtually, given the broad geographical representation we have. As agreed by the subgroup, minutes will be recorded and shared with all members, and we might form additional working groups to address specific tasks. So the output, we're hoping for a comprehensive guideline document for clinical eye tracking and nystagmus. We hopefully include supporting materials like protocols, flowcharts, and training resources, and recommendations for future research and development. And we can review these annually or as needed, and we can update the guidelines periodically to reflect new evidence and technological advances. So that's the draft we've come up with. Broadly, is everyone happy with that? Do we need to add anything, modify anything? I guess I can see mostly. I can see Matt's hand has gone up.
I would only add that, as we discussed last time, this will probably end up being a fixation guideline informed by the use in nystagmus, which will be the typical scenario in which it's used. But otherwise, yeah, fine.
Okay. Yeah. Right. So we can we could specify fixation, or we could leave it as we have formulated. What do people feel?
Well, I guess this could emerge as we go. You know, we'll see how it ends up.
We can modify it. We can always revise it as we go along.
Yeah.
Okay. So that's that. And then, so I thought it'd be good to be clear on authorship before we start out on this body of work. So what we've done is drafted what makes a substantial contribution. So basically modeled on what normally happens in journal and manuscript submissions. So basically meaningful participation, development or refinement of the consensus guidelines, drafting or critical revision of the manuscript, and contribution to data interpretation, methodology, or expert reviews. So any one of those we would consider substantial contribution. We also want timely engagement, so we do not want to be dragging our heels and waiting several weeks for one or two people to get back and delaying the whole publication. So what we suggested is certain timeframes. So authorship confirmation within 10 days of invitation, review of drafts within 15 days of receipt, and then final approval before any submissions within 7 days of request. And then we have a non-responder section. So if people fail to respond within specified timeframes, we'll notify them once with a final reminder. And if we don't receive response within 5 days, then we'll remove them from the author list and acknowledge, if appropriate, in the acknowledgement section. And we can make exceptions for extenuating circumstances, for example, medical leave or travel without access. And then accountability. So all authors must agree to be accountable for all aspects of the work and ensure integrity and accuracy. everyone must submit a complete and accurate conflict of interest statement prior to submission. And then on final review, all authors must review and approve the final version of the manuscript before submission. So we thought that would be a reasonable kind of set of authorship guidelines and timeline. Is everyone on the call in agreement with that, or any modifications? Okay, we've got general nodding, which suggests Rebecca and I were quite thorough in preparing these. Right, so then back to the agenda we're flying through. So I think progress updates. So I think this is where we'd start getting into some of the meat of what we need to do. So I think we need to review what questions came up. So the survey went out, well, not the survey, to everyone. What kind of questions do clinicians tend to ask when they're assessing nystagmus, just to kind of set us up for how we should write, for example, a fixation protocol. So if I pull up the document, I think there. Can everyone see that? Is it big enough for everyone to read? Okay. But I like the first question that's come up. Does this patient have nystagmus? And yeah, Matt put the link into the document as well. I thought that was actually a very reasonable first question to start with, because then that would determine what you do afterwards, doesn't it? And what's been written in here is relevant tests. And I think I noted as well, as we went through this, fixation comes up in nearly all of the questions. But there's fixation in various gaze positions, monocularly, binocularly, and spontaneous viewing without fixation dot has come up.
Yeah, that's what I added, because we are actually doing some measurements on nystagmus, and we also have a stimulus without any fixation point to check if there's nystagmus. The fixation points can influence the nystagmus, so that's just the stimulus we have. So maybe it can be useful to add it as well. It's no fixation, but the question is it a fixation protocol or a nystagmus protocol? So when it will be a fixation protocol, then it can be omitted. But we can discuss this, I think.
Okay. Well, you could still be a fixation protocol, and the first step is actually record without fixation or something along those lines, then put on the fixation target. Jay?
Yeah, can I just ask, it's my own ignorance, but what would that show if you do, if you're looking at fixation with them without a target, what would that show in terms of differentiating pathology and stuff, or deciding if it's nystagmus? I don't know enough to know the answer.
Yeah, some disorders, when you have, for instance, when you have a black background, you can have spontaneous nystagmus in certain disorders that can influence the nystagmus during free viewing. So that can be interesting to look at.
So would that mean you wouldn't spot any nystagmus if they had a fixation target, and therefore they'd be told they didn't have nystagmus? And you have to do this to say that they have?
No, it's more for making a distinction between different types of nystagmus. So some nystagmus can originate from the retina.
Yeah.
And depends on the input. So.
Okay, I'm just thinking, because this, just for my very simple brain, if this bit we're trying to stick to, do they have nystagmus or not? Do we actually need it in that section? Just a minute, it may crop up later.
Maybe we can move it to the next section. So that's not, it has to be somewhere, I think. So
yeah, I'm just thinking from my simplistic clinical brain, to answer each of these questions, we need to keep it as light and absolutely to the point as possible per part of this question. So I just wonder whether that possibly needs moving somewhere else, or it will crop up in another section. Maybe.
Somewhere else, maybe. Yeah.
I think it'll come up in there's a section on what type or characterizing the nystagmus, and then you can get into the nitty gritty of how we would do that. Matt?
Yeah.
Just wanted to just remind the scope of what we're doing. So obviously this relates to clinical only, but if there are clinical uses, then that's absolutely important. We have discussed, although haven't maybe come to a final conclusion on whether these guidelines would have both a minimum standard, which you try to get in everyone, even in infants, for example, and then an ideal standard. But that ideal standard would still not be kind of research grade per se, but it would be, if you've got the time and you can, then you would do all these things. So it may well be that spontaneous viewing is something that fits into that, or need to look at the evidence, because I'm not aware of that myself.
Yeah. I think we can in this first iteration, as we put in everything that we think might be needed, then we can start refining it as the group review it and put in the evidence offline, and then we can reach a consensus on what we think absolutely needs to be done in all clinical assessments of a patient with potential nystagmus or other eye movement disorder. Okay. So, so fixation in various gaze positions, monocular, binocular, seem very sensible to me. Actually can't think of anything else to add. If you're just going very, very simply at the very top of that decision tree.
Yeah, either you're looking for they haven't got an eye movement disorder, or you're looking for it's not nystagmus. It's a saccadic anomaly or something, and that's essentially it, isn't it? Which you'll pick up from those things, and you'll pull out MLN, FMNS, INS, wave, all sorts of stuff from there. Yeah, I agree. I can't think of any more bells and whistles to add on apart from those first two.
If I start thinking about other systems, so we've written down one system. So there's Saccades, there's Smooth Pursuit, there's Virgins, there's OKN. Yeah, Matt.
Sorry, I'm just adding. You might want to add convergence to that as well, because you've got things like convergence, retraction, nystagmus. If we're really trying to find absolutely everything, some people will have although it's usually the other way around. Some people will actually have nystagmus get worse at near if it's infantile. So just if we're going and completely filling in all the possibilities.
Okay, so that's the Virgin system.
Yeah, I think that's fair.
Decay, your vestibular system, OKN. I'm just thinking about how we would do this and say other. Things to ponder. We could just put each system down and go, what would we put in, or do we need to include something from that system, perhaps? Arthur?
Yeah, I was just wondering whether fixation is too specific, because in the kinds of patients that I deal with, which is inherited retinal diseases over a very large ability to see, fixation or fixation dot is much too specific. The key question is whether there is any visual feedback, there is any kind of a input that would help or input into a closed loop system versus an open loop eye movements in complete darkness, for example. And so what we see, for example, in Leber conjugamaurosis patients and retinitis pigmentosa patients and others is sometimes when you cut all input out, there is no vision, it's in complete darkness, there is still nystagmus. And in other patients, there is continuous, that there is a disappearance of nystagmus once you have no input. So none of that detail makes a difference here, except that I'm just wondering whether fixation or fixation dot or visibility of a fixation dot for a specific patient is much too specific.
Okay.
So my understanding of that, I mean, at the end of the day, using a fixation dot to get them to try and look at something, it doesn't really matter if they can't see that. We're still looking at whether they've got any eye movements, abnormalities, right?
It's the system itself.
We're still going to pick it up.
Isn't it? As opposed to saying the target, it's the visual system. We're trying to go by system, aren't we? If we're modeling after ISEV, we're trying to go by different system as opposed to by condition, so that we can be quite systematic in how we approach it.
So my question will be, do we specifically need to say fixation dot? It's just fixation target, isn't it? Yeah. Matt?
Sorry to throw another spanner in the works. I've forgotten about all of our vestibular colleagues. So if we're looking at nystagmus, both infantile, neurological, and vestibular, you'd have things like the Dix-Hallpike test as well. Now, we may just decide that that's out of scope. There's nobody here representing that. I have recently been to visit some people who do this, and you know, they too actually could do with guidelines. But again, just to throw another spanner in the works, there are other. You could do head maneuvers as well.
Yeah. So that could be an extension to what we achieve from the.
I would err on the side of putting that in. I think this needs to be a bucket exercise at the moment.
Yeah.
Because you're right, that absolutely is a form of nystagmus that you have to do something different to pick up the nystagmus. That's what we're talking about, isn't it? I think you stick them in and then we decide on that remit later once we've seen how big the buckets
are. Or whether we need to bring in specific expertise to advise on that.
Yeah.
Because when I see those maneuvers being done, they're not exactly on the night tracker when they do it. They are just sometimes clinically observing in a clinic room when they do the maneuvers.
Well, often they are. They'll have the vestibular nystagmography goggles. Yeah.
It's a very different setup, isn't it? Fatima, or is it? Sorry, Gemma is first, and then Fatima.
Yep. So I think the open loop, closed loop is an important issue, and I think we just need to say. I think it needs to include. Is there a fixation target present or not? And I think that would kind of clarify some of the open loop, closed loop, but we should probably include what we mean by that.
Yeah.
Because my assumption would be that you're showing the patient a fixation target that they can see. But the example given where they've got kind of very poor vision, you can show them all the target in the world, you know, clarification that they can see the target would follow that.
Okay, and Fatima, you were next.
Hi, I just actually wrote earlier on in the next section about convergence, and also I know it's very rare, but we have had patients where the nystagmus is actually brought on by the pursuit eye movement itself. So I put that further down, but I'm not sure whether you wanted to put it up in the first section, that to look at the patient that you suspect he might have nystagmus, to look at their pursuit.
Yeah, that's true. You're thinking like maybe something like I'm thinking.
I'm not thinking
because I know when you make them do saccades, you'll pick up. Sometimes you'll get a nystagmus, although you can see that.
We've had young patients where the actual eye movement itself brings on the nystagmus. It's very rare, but we have seen it. So if you're going to go through the different eye movement subsystems, obviously that'll, you know, I've always started with saccades. I mean, after looking at fixation, going to saccades and pursuit. So it's just, I suppose, if you're going through all the subsystems, you will pick it up.
Yeah.
So I'm not sure where you're going to put that in there if you're going about going through the subsystems like Matt had mentioned. And looking at VOR and VOR suppression and that sort of thing as well. And obviously OKN, I haven't seen the OKN in there either. Even just an OKN to a drum, if we don't have anything more sophisticated. And obviously, if you have an infrared camera, you can look at presence and absence of nystagmus in the dark, which does, you know, it does change. But obviously, I don't think many of us have that sort of.
No, and a lot of bearing in mind where we're trying to get this into clinics that may not have facilities. They might just have basic eye tracking, if at all, and very limited expertise in order to use it. So we need to be very, very clear on what would be useful, what people can do when they have specific questions that they need to answer as they work through the systems or decision trees as they use the trackers.
Yeah, but obviously you can put convergence and pursuit there because you don't need.
Okay, I saw other hands go up. Where's that? Oh, so I think it's Fiona, and then Matt.
Hi, thanks. Just some brief comments on the things others have brought up. So when we do the VHIT tests for the vestibular system, you would very often see nystagmus occurring as a result of the head movement. And that can also be diagnostically relevant in terms of isolating the source of the nystagmus in the vestibular system, and depending on the direction of head movement and so on, and the resulting direction of the nystagmus beat. And the other thing that I thought might be relevant for some was that when I was testing people with vision loss, I did some experiments dividing those who have peripheral vision loss versus central vision loss. And you tend to see nystagmus much more often with central vision loss than with peripheral. And in fact, we were able to find that in people who have central vision loss related nystagmus, that the presentation of star fields to the peripheral vision actually seemed to halt their nystagmus. So just to say that it may be that you want to actually categorize different stimuli in order to see how the patient responds to stimuli presented either to peripheral vision or to central vision, and it might really have an effect on the presence of nystagmus.
Okay, and we've got Matt and then Rebecca.
My comment was just to follow up on Fatima's point about doing it in the dark. As Jay said earlier, I think this is good to be doing this kind of as a bucket exercise now. So even though I agree that we may not include putting them in the dark, if there is a clinically relevant reason to do so, then we should maybe just collect that now, and then we can later on prune out the things we're not going to do. Yeah.
Oh yeah, no, we're going to just put everything in. This is what this first exercise will be. Rebecca?
So just taking it back a step, I'm wondering if the first question should be, does this patient have manifest nystagmus? Because then all the other bits would follow. So, you know, so we're talking about, so is it there? Is it present? Can we elicit it under different conditions? I'm just wondering whether, because obviously some of these things that we're talking about now, so on head, you know, nystagmus on head maneuvers, you know, the vestibular in the dark, you know, I'm just, I don't know, you know, as a first step, would that not be what would be thinking of? Is there a manifest nystagmus?
Gemma?
Yeah, just to follow on from Rebecca's point, it's almost like we're asking, is the nystagmus apparent or can it be induced?
Yeah.
Because what we're describing is, well, we could do this and it could happen. So I do think that might be helpful, because then it would specify, if you've not got an apparent nystagmus to start with, you might want to consider doing these things to investigate whether it is inducible or presentable under certain either testing conditions or certain viewing conditions.
Okay. Breed? Oh, Fiona, sorry, yeah.
Just really briefly following on from Gemma, I think you would need to define whether like pose would be something that's induced or manifest. If the nystagmus is apparent when they're placed in a certain angle or something like that, then it might not be so clear cut whether that is in the same category of manipulation as maybe changing the stimulus or doing a VHIT test or something like that.
Okay. Let's see if there's any other. Okay, and I see Fatima's put her hand up.
Sorry. I just worry about the use of the word manifest, and I don't know if the orthoptists mean something different to the clinicians. I always think of when I talk about manifest, or when I ever think of manifest, I always think of manifest latent, as opposed to just being apparent. And that's because I'm not an orthoptist, so I do get confused, and some of the orthoptists I've spoken to also, I think, don't really know what they mean. Is it are we talking about manifest latent or just an apparent nystagmus that's there because of the head posture or whatever? I don't know if Gemma can explain or add to that.
Yeah, I mean, I think using manifest probably does invite a bit of a tangle of confusion with manifest latent. I guess what we're asking is the nystagmus kind of obvious at first eye tracking, or is it that you have to do something very specific to elicit the nystagmus?
So
So
I don't know.
I would prefer not to use manifest, something like apparent. Whilst it's not very scientific, I think it's probably less of a tangle with manifest strabismus and manifest MLN.
Okay, Jay?
Yeah. So looking at this broadly, I think we've got two options, haven't we? The problem for me with starting to say manifest or apparent or blatant, then we've basically just selected a whole loads of types of nystagmus that we're looking at and not a load of others. So I think we either bucket this completely and include absolutely everything, or we move away from it, which I think we might end up doing anyway, just as my gut feel when we see the size of the buckets, and move back to what we said before, which was, because we are here telling somebody how to do something clinically, which we've always said we don't want to do. We want to say, if you want to test that thing, you do it this way, rather than say, if you've got this clinical question, you need to do these tests, because they are so different. Somebody with a vestibular disorder where you're trying to pick up nystagmus is so different to an INS or an MLN, right? They're wildly different. So the other option, I think, is maybe at risk of being really annoying, is to move away from these questions and move back to, if you want to test OKN, this is how we suggest you do it. If you want to test saccades, this is how we suggest you do it. Because otherwise we've definitely got a couple of toes in the telling clinicians what they want to look at for certain clinical scenarios, which we said we didn't want to do. Sorry, that's not massively helpful.
Rebecca?
Yes, so Jay, so I agree with that, because I think where my confusion is just because I thought we were thinking of testing, so we sort of agreed, I thought that we were testing the fixation system, and now the conversation's moved on to VOR and OKN and saccades and pursuit, and that's where my confusion has now come from. So are we just thinking about the fixation here, rather than thinking of a nystagmus guideline or whatever it is, whatever terminology we decide to use, I'm a little bit confused now, just because other eye movement systems have just been thrown into the mix. So I don't know if Matt can try and see if your hand is next.
So obviously this group was brought together as a set of nystagmus experts. That's the expertise we have here, and although fixation is clearly going to be the main thing that we're going to work on, there will be some feed into the other standards as well. The reason that this standard is not being produced in parallel with other standards is so we can learn from the process, and it may well be that we kind of set some groundwork for a few standards during this process. I agree with what Jay said, that actually we are maybe just going down a slightly more clinical route than we need to in this respect, in terms of giving the actual what you need to do with the patient. If you look at this list of relevant tests here, they all basically, in terms of what the eye track is doing, will be the same thing, where other than being whether there is a fixation dot or not. If there is a fixation dot, it might be here, it might be here, it might be here, it might be here, but it's the same protocol. So I do think this is a useful exercise, though, because this is going to get us to understanding the tests that clinicians are going to need guidance on. So I don't think it's useless for us to be doing this. And yes, I think we will produce a fixation guideline, but we're going to have in the back of our minds how this will be used, and maybe we will also set some groundwork for OKN, for pursuit, for saccades, and so on. But we would ideally, we might just set some rough ideas as to how that will work, and then there will be other subcommittees to work on those particular guidelines, and hopefully we can do the rest of them in parallel once this one is complete, whatever this ends up being. Okay.
Well, I was going to suggest, why don't we look at the rest of the questions that came up for nystagmus, and that might help frame things in context. I suspect as we go through fixation, we might find, oh, hang on, it would be useful to get some information on virgins or smooth pursuit, but as we get through the first system in the context of these questions that were put out, we'll probably get a better idea as we go along. Fiona?
Yeah, thanks. Just a very brief comment on this section. It could be that even taking fixation, that we could subdivide into fixation with a stationary head versus fixation with a moving head, and that would actually give us VHIT, which is essentially a fixation task, but just with the rapid head movement involved and all the other the other tests really under the banner of fixation, perhaps.
Matt?
So I would follow up on that, Fiona, and say that actually the eye tracker is going to be doing the same thing in both those situations. So given that ISCET's remit is in what the eye tracker is doing, unless it's of course feeding in head position data, which I understand.
Exactly, yeah.
Yeah, maybe that is then in that case. Okay, yeah, fine.
So in the interest of time, Helena, I think we should move on and look at some of the other bits that are in there as well.
Yeah,
I think that would be quite useful.
Doing that. Yeah, we're moving on. Second question: what type of nystagmus does this patient have? And I think we've kind of been discussing that already, but we've come up with fixation in various gaze positions, monocular, binocular, distance, near, resulting from head maneuvers is in there, and for a number of minutes to check for pan. Spontaneous viewing is in there. Check for nystagmus or pursuit task. People have been adding to this since this morning. Presence of head posture or head shake, binocular and monocular intensity. So that's quite a lot, just under, actually that's going to be a huge proportion of it, I think. What type of nystagmus does this patient have? Just concentrate on fixation system. Fiona?
Yeah, I would maybe just add under different body pose as well there. It seems to be referring to head pose, but for vestibular disorders, it would be body pose also.
Mm-hmm. Yeah. Next one, does this patient have a null zone? So once again, fixation, various gaze positions, in their head posture and out of it. During central fixation sometimes, and useful if suspect the gaze position targets won't be in the right position to capture maximum difference. Monocularly, binocularly to check for MLN. At distance and near to check for convergence null. For a number of minutes again for a pan. And then see some of the other systems are coming into this as well, aren't they? Horizontal smooth pursuit testing sometimes useful for corroborating evidence for those with horizontal null and limited attention to static fixation. So we could just concentrate on fixation and then just have a little box aside going, other system may also need to be in maybe useful, or if we just want to focus on fixation for now. And then the final question that's come through, is there a change in nystagmus from a management option or intervention? So that again comes up with fixation. So I think we just need to make a decision now as a subcommittee. Are we just going to focus on just drafting fixation? What we need to do when evaluating fixation in terms with these clinical questions in mind? I think everyone is confused now.
I think it's a good place to start, and I think you can set a fixation protocol and say that it could be performed under the following conditions, which covers most of what we've got here. I've just moved, for example, spontaneous viewing into it is a fixation task, right? It just doesn't have the dot. And there was a point on the second question which was said, measuring nystagmus intensity. Well, that would come from fixation as well. So a lot of this does really fit under fixation. So,
right. Okay.
If only as a starting point, we could do that and then look at what else needs doing afterwards, or if we just feed into those other guidelines later. Okay, so shall we just go with, let's keep it simple. Let's just focus on the fixation system for now in the context of these clinical questions, and maybe get drafting on a sort of guide. Yeah, Fatima?
Sorry, just when I have a patient with nystagmus, one thing that we haven't, well, we mentioned it, but it's not there, is I always look at the presence or absence of OKN, because that's actually clinically really important. As Jay knows, if OKN is present, then you've got to start worrying about a neurological nystagmus. And I know the subsystem is not there, but it's quite an easy test to do, just to an OKN drum or a cloth. What do you guys think?
So Matt gave a thumbs up.
So I'm still struggling with what we mean by a fixation test now. I'm sorry, I might be really dumb here. We're talking, are we doing a guideline on fixation, i.e. how good are you keeping your eye still? Is that essentially what we're doing? Because there are other groups who are going to talk about how to measure OKN, saccades, VOR, blah, blah, blah. Is that what we're saying? Or are we trying to include elements of those other things in the context of nystagmus?
Matt.
So, well, Helena, are you able to answer that? Or I don't want to jump
go
in.
ahead.
Okay, so basically, as I said, we're the nystagmus experts. I think what we're primarily going to be working on at this point is a fixation guideline, but we'll obviously have some insights into the situations in which clinicians will use the other tasks. I think this is a reasonable way of approaching it. We can have clinicians with expertise in different disorders and saying, how are you using eye tracking? How would you use eye tracking if it were more standardized? And what tasks would you need? So we may be able to lay some groundwork for those other standards as it pertains to nystagmus, but then perhaps they'd be taken on by other groups.
But we're only talking about fixation. So we're thinking about the nystagmus patients we see, what elements of fixation testing is useful, creating a big bucket list of all those things, and then coming up with some plans of this is how best, this is second best, this is third best. Is that the plan?
It's a bit like when we select the VP, ERG, or EOG.
Yeah. Okay. So when we start talking about whether smooth pursuit is useful for our patients or VOR is useful for patients, that's irrelevant to this now, right? We're just talking about fixation. Correct?
Well, we want to write the guideline for fixation, but doesn't mean we don't want to make a note of, in this scenario, we might also want the information from the OR, or we might want the information from smooth pursuit or from Virgin system. Do you see what I mean? But
that's where my confusion is, though, because if we're doing a guideline on fixation, but mentioning all the other things we want to know, we're essentially writing a massive guideline for everything, which is what we're trying to avoid, is it not? Do you know what I mean?
The issue, Jay, is that this is the very first standard that ISCET's producing. So those guidelines will all be in place eventually, and they may well be separate subcommittees to work on each of them.
What guidelines? What guidelines?
So a guideline on VOR testing, OKN testing, pursuit testing, saccade testing. And I mean, those are just the high level tests. We're also going to have a guideline on the file format, a universal file format. Then the data pre-processing steps, so that there's loads more work to come after this, and our role, we and when we first got this group together, we had in our minds we were going to do a nystagmus guideline, and it's kind of come around to the idea that actually it makes more sense in the context of other guidelines to do this system by system rather than disorder by disorder. So that's the slight confusion here, but I think it's still
so in that case we need to focus hard on this is about fixation and avoid saying actually in those patients I quite like getting this and that and that and this, because that's not what we're doing, is it?
It's still useful though, because we are currently the nystagmus experts together in one place, and we can feed into those. Even if somebody else, another group, then takes those on, there'll be intersections of this group anyway. So I don't think it's not valuable for us to be noting the uses of it in nystagmus. But maybe if we're going to start with something, it makes sense to start with fixation.
We're going to be the tree trunk, Jay, and then there'll be branches. Going from what you said before, Rebecca.
Yeah, so I'm with you, Jay. I'm a bit confused still as well, because really this so in here all the questions are what type of nystagmus does this patient have, blah blah blah. So we're always referring to nystagmus, but actually that's not what the question that we're asking, is it? The question is does this patient have stable fixation if we're doing a fixation guideline? So, and if it's a fixation guideline, then at this point in time, we need to make a note of the things to do with other systems, so like VOR or Virgins or whatever, but it doesn't go into this. Is that what we're saying?
Yes.
So we have kind of like almost like you say, it's a tree trunk, isn't it? So you would have branches going off that would probably divert into the other systems. Is that what we're saying?
Yeah, and I think the reason that started with nystagmus, you can correct me if I'm wrong, Matt, is because we needed somewhere to start, as in we needed to know in what some clinical scenario would we be using tracking, and then what information we need to get, or the minimum amount of information from each system to give us the appropriate information needed clinically. We're not telling people how to diagnose clinically, but we're just
but it might not be
guidance
that you come out with at the end of this.
Yeah, exactly.
That affects fixation.
Yeah, and it gives them that appropriate information that they might use in different scenarios. Then Gemma, then Arthur.
I just think we're all going round in circles with the
Yeah.
same point, because the second paragraph on this document says the purpose is to define a list of clinical questions that may arise in the context of nystagmus assessment. So that is not specific to fixation. That is saying this is about how you investigate nystagmus. So I think we need to kind of decide this is either a fixation guideline or it's a nystagmus assessment guideline. If it's a nystagmus assessment guideline, we may say test OKN, COKN guideline. It doesn't mean we have to put it in, because that's what Jay's saying. If we put everything in, it's going to be massive. But I guess if it is a true nystagmus assessment guideline, it needs to highlight that some of this information is going to be in other guidelines that will follow. But if it's a nystagmus assessment guideline, it's not a fixation guideline. So I think we're just all going round and round because fixation.
Well, the first step is that we broadly draft out what a nystagmus guideline would look like, and then go into detail on just one system within that. Does that make sense?
I think that's fine. I think that's just probably. I think it's our understanding of.
Yeah.
So therefore, you should include things like OKN, but please say OKN guideline, and that's what's going to come in parallel.
Yeah. So we just need that flow diagram basically, and then we'll go into detail on fixation. Right. Okay. Arthur?
Yeah, I am also completely confused. I thought that this was eye tracking was the basis. And so how a given lab, a given clinician in a given patient evokes the nystagmus should be completely out of this. That's too big an area. That's up to the clinician or the technician or whoever that's asking that question. The end result should be you have moving eyes, nystagmus if you want to call it. And then you have eye tracking. What do you do with it? I thought that was the question, that how to measure eye tracking in a patient with nystagmus, however that is produced. That's too big a question, I think. And fixation certainly is too big a question, I think, as to what accounts for fixation, certainly in my world.
Okay. Fatima, then Matt.
Yeah, I'm confused as well, but I do agree with Gemma. I think, are we talking nystagmus or are we talking fixation? I mean, if the other thing is we have often had patients referred with having nystagmus, but actually it's not nystagmus, it's flutter, it's opsoclonus, it's saccadic intrusions, it's square wave jerks. So does it have this patient nystagmus? And if it's not nystagmus, what are these abnormal eye moves? So we need to, and that will come under fixation, but I think you need to sort of think of the patient as a whole, as like a holistic approach to that patient, and then maybe go into the different subsystems like the fixation or saccadic systems or whatever. Because I mean, my feeling as somebody who does see patients with nystagmus is I look at the child, it's normally children, and I'll see what their nystagmus is doing. I'll try and do as much as I can, binocular, monocular, etc. And is it actually nystagmus or is it flutter, for example? And then maybe look at the fixation system or the saccadic system. Anyway, that's all I wanted to say.
Matt?
I'm hoping to provide some clarity on what we're doing here. So going back to the last meeting, we hadn't at that point decided which system or systems would be the most important. So this is a separate exercise. This is a preliminary exercise we're doing we're getting the nystagmus experts to decide on what tests are relevant to nystagmus. Then, as a completely separate exercise, we will then move into defining a fixation protocol. So the actual publication, I understand or imagine, would probably be the fixation protocol. We can then potentially have something else to refer to how you might use that protocol and the conditions in which you might change head movements or fixation targets on or off or positions and so on. But this is a separate two-step process. So if that helps to understand why we're currently talking about nystagmus and all the situations you might, all the eye tracking situations you might use that in, and then we'll go on to look at fixation protocols specifically.
Okay. Ruth, so I bet she's got some insights from her experience.
No, but these conversations are really familiar. And
Yeah.
I know that when developing electrophysiology, you would have people saying, well, you can't do a VP unless you finish the PERG and you know what their fundus looks like. And they're absolutely correct, except you can still write down how to do a VP. And you don't have to, in that document, tell people you need to check the fundus and you better check the PERG. That's not what the document's for. And I understand the conversations here. I'm hearing a need for a diagnostic guide to the assessment of eye movements, right? But I think what's achievable is that it's okay not to be comprehensive. That the issue here is you've got a subject who's walked into your clinic and you think they've maybe got nystagmus, or you can see they definitely have nystagmus, and you've got an eye tracker. So what do you do? And just write that down. You don't have to then say, oh, but you need to check this, because you're working with clinicians who know all that. I mean, we're not teaching people to suck eggs here. We're teaching them that they don't know, which is I switch on my eye tracker, I upload my nystagmus protocol. What should it do? And I think if you can keep it as tight as that, it will solve some of the discussion problems that are arising.
Mm-hmm. Thank you. That is very clear and very useful. Okay, I think a final comment from Breed, and then we need to kind of decide what we're doing. Oh, sorry, Fiona, sorry. I keep reading the middle name.
Oh, okay, thanks. Yeah, I kind of agree with what others have said, but I'm just wondering if it could be useful to consider, like, the stage above this, an overarching collection of disordered fixation standards could include nystagmus, and then you have so many different potential disorders of fixation which aren't nystagmus that they would be other standards. So maybe at the very highest level you have a difference between disorders of fixation, which would include smooth pursuit disorders, VOR, different disorders under that flag, and then another which would be disorders of saccadic movement, where you would have many other standards falling under that rubric as well. And that if you try and bring all the other fixational disorders in under nystagmus, that you're not going to have any clear boundaries at all between one standard and the next, because they're so integrated actually. But one category that does seem pretty obvious is disorders of fixation versus disorders of saccade, and that this would be one of the disorders of fixation, and maybe keep the others, which include vestibular tests and so on, as other disorders of fixation, and maybe a separate standard. It seems that the question is about where to draw the line between separate standards, and you can either go for an approach where you include everything relevant, or where you really just take one major categorization and look at all the disorders underneath them separately.
Okay, right, Matt?
Sorry. I think we can probably do without actually having to mention the disorders at all, because ultimately the protocol is just going to be, where is the target, how long is it on for, what color is it, that sort of thing. And so all of that can probably be sidelined when we come to actually produce the protocol itself, which that would be the next exercise. That's my view.
Okay, so what I'm hearing here is we can't do everything, basically, because we've just gone through all systems, a huge range of scenarios, and I quite liked Ruth's suggestion that we just frame what we're trying to do as a starting point. So we're taking this patient has walked in. The question is, they look like they have nystagmus, and then we write out what you would do in terms of fixation protocol in that scenario as a starting point. We're not saying it's going to be the complete thing. Let's just have that as a starting point, get everything together on that, and see if we can reach consensus on just one small aspect of eye tracking. Does that make sense? Because we can do this offline. and then get a consensus together, because we need to kind of update the people who aren't in this meeting as well. Get this all together in one place. Rebecca, yeah?
Yeah, so I agree. So if we all sort of write our own protocol, so we haven't, as Ruth said, and I think she's brought us back to where we need to be, because you know, ultimately that first question, does this patient have nystagmus? You know, when a patient is sent to me, it can be from the optician who suspects it's nystagmus, but they don't know that it's nystagmus. And as Fatima said, it could be a whole heap of other things, because until we get them on the eye tracker, unless it's really obvious, we really don't know. So are we suggesting then that, so that we all write our own protocol? What do we do with a patient when they first present to us? Yeah, and then we can pop that all together, like you say, and see where we agree and where we don't agree.
Yeah,
and that would be a starting point.
Yeah, if we just write out that one scenario that everyone responds to, this is what you're presented with. What would you do for a fixation protocol on your tracker to assess this particular scenario? And that will give us a starting point.
Yeah.
Can I check at this point what the parameters of that will be? So, for example, you know, for a fixation protocol, there's really not a lot to say. There's what kind of fixation target are you using and how long is it on for, right? And then so a lot of this is going to come down to the analysis side. What do you do with those data? Or were you thinking about more than, just so we know what we're all actually producing between now and the next meeting?
I guess, Rebecca, what do you, like, I know you were just like this, I know in my head what I'd be doing, but.
Yeah, so I think, you know, so I think if we've got a patient in front of us, they think it's nystagmus. So the eyes are moved, they think the eyes are unstable, are not stable. Okay, so what are we doing to test that, to see whether the eyes, the question, so this is taking it back again, so we're not saying do they have nystagmus necessarily, are we? It could be any sort of fixation disorder, couldn't it?
Yeah.
Although we all specialize in nystagmus, you know, it's like, what are we going to do? As we've said, we've got a patient in front of us, we're going to switch the eye tracker on, we're going to pop that eye tracker on, and then what do we do? What are we doing with those patients in order to see whether their eyes are normal or not? Is that not?
Yeah.
Their eye movements are normal or not? Is that what we're?
That's what I thought we were doing.
And some people may have less.
But we can merge it all together and have a review and consensus.
But are we limiting this to just the things that the eye tracker is doing, as in just basically the instructions sent to the eye tracker, rather than what you're doing with the patient in the room?
So, but we do have to give the patient some instruction as well, don't we?
True. Yeah. So the instruction is important. Actually, that is a valid part.
Yeah. So the instruction to the patient. Well, what we're doing with the eye tracker, the instruction to the patient, and maybe even if we talk about what our targets are looking like.
Yeah.
You know, because we all have different ways of displaying our stimuli, I would imagine. I mean, Matt, you'll be able to say, because obviously you've been traveling around, and I'm sure we're all doing it slightly different, aren't we?
Yeah.
Yeah. Yeah.
Absolutely, you know, there are big differences everywhere I've been. Yes, yeah. I guess fixation is the simplest protocol of all in terms of the test side of it, because it's just one dot. You know, we haven't got to worry about the saccade step sizes or anything like that.
Yeah, and we're just taking this as a starting point because we need to start somewhere.
Yeah, I agree.
As simple as possible, and then we can work out what we're doing from there. Okay. So I guess our next steps will be that, well, I'll get all the minutes together from this meeting so that we can update everyone who is not in this meeting. And then I think Rebecca and I will need to draft that specific scenario so that we're very clear what everyone needs to return. We'll set a specific date for everyone to return what they would do, and then we'll merge everything together for everyone to review, and then we'll see if at our next meeting if we can start reaching a consensus on certain elements, or if there's anything controversial or anything that needs to be added, and then see if we need to expand out from there, or we need to see what we get from our little tree that we're planting, basically, and how many branches are going to come out of it or need to come out of it. Okay.
Great.
Right. Any other business, I guess? We have run over. Well, I was aiming not to run over, but we'll. Doesn't look like there's any other business from what I can see. If I stop sharing, perhaps I can see all pages.
Do you think, as well, just to add, I mean, would it be worth us looking at the ISCET stuff? You know, the way, Ruth, would it be worth us looking to see, because I'm actually not familiar with that, you know, to look at what you've put together for your...
Yeah, and if you, I'm very happy to offer. So we do have a standard set up, so a list of topics. So we've got technology, clinical preparation, and lots of bits and pieces like that. Herman knows them all off by heart, so does Shan. But what we could do is sort of synthesize a set of subheadings that might be a useful structure to start hanging things on, if that's useful, and that could be based on the format we use in ISCET.
Yeah, I think that'd be really useful. Jay?
Yeah, I think that'd be incredibly useful, because I've just been pondering for the last 5 minutes that this is not sounding much like ISEF at all, frankly, because ISEF don't tend to say you've got a patient with this massive group of potential diseases, we suggest you do this. They say, if you want to look at ERG in this age group, here are the standards. If you want to look at, do you know what I mean? We're definitely moving away from that. So having those headings would be super helpful, because we are constantly looping back into telling clinicians what to do in clinical scenarios, which we've all said we're avoiding, but it keeps coming back.
No, but what we're doing, Jay, is we need to frame it somehow to give us a starting point. So it will end up being a fixation. Yeah, but we need, because otherwise, if you go,
Yeah, but no, I think that list of headings from Ruth would be super helpful. We should literally try and model this on ISEF to avoid mission creep, which I think we're guilty of.
Yeah, I think why reinvent the wheel? You know, if there's something there to direct us and assist us. So yeah, Ruth, if you could do that, that would be really helpful, I think.
Okay, so we're clear. So we're not going to do everyone provide their guidelines or what they would do in a specific scenario. Are we going to look at the ISA first, or are we doing both in parallel?
Well, I'm happy to turn around. I'm happy to turn around the heading list really quickly, so that if you guys wanted to furnish, and I've got a protocol too, and try and group it by that heading, if that would be a useful way of doing it, make a big old spreadsheet, and you can just lump bits of text under each heading. And then somebody's got a hideous job of trying to synthesize that into something useful.
Because I still think that in our mind, we'll still be thinking about what we're doing with our patient, won't we?
Yeah.
And it will just be kind of, it reminds me a bit of in vivo. I don't know if anyone's done any qualitative analysis. It reminds me a bit of in vivo qualitative analysis. Yeah. So, yeah.
And that usually has sets of questions, doesn't it? And then people reach a consensus. So we have to, you know, fixation disorders is huge. So
yeah, should we do that then?
So we're going to get the headings first, but we'll have that to frame what we're doing. And are we going general fixation disorders, or are we actually going to use that little, this is what we typically see, what would you do as a starting point, and then expand out afterwards? That's what we need to be clear on before we go, because it's two very different things that we're doing. If it's just generally, you're just going to test for any fixation disorder. Jay?
I think we need the stuff from Ruth first. I think we really need to model this on ISET. We are struggling massively to have a remit here in the direction. I think we need to make a call whether we want to basically try and copy ISEF for eye movements or not. If we do, we look at those documents and say, well, what's our equivalent for that document? What's our equivalent heading for that section? And do it that way. I think that will be a lot easier, because otherwise we're just going around the houses round and round, aren't we?
Right, let's have a vote. Right, so do we all want to wait for the ISEF and then make a decision maybe offline? Like, we don't need to meet, we can just do an email and then follow up with what we do afterwards based on the review of what ISEF headings are.
Yeah, I think that would be really useful. Anybody disagree with that?
That might be the easier way.
Because otherwise we could be doing something, we could be spending time doing something, and then, you know, that is nothing. So I think, so nobody said that they are really against that. So yeah, I think
right, we'll do that and then revisit afterwards, and then determine the next meeting based on that. But I think we've had useful conversations today anyway.
Definitely, yeah.
So we'll get that into the minutes. Big job for us, Rebecca.
Okay.
Okay, right, we'll do that. So as soon as we get that information from Ruth, I'll distribute it to the whole email list along with the minutes, and we'll set a deadline for response and decision via poll, and we'll go from there.
Thank you, Helena and Rebecca.
All right.
Then should we just hang on, Helena? Should we hang on just for a second, just to start our next meeting? Yeah, great.
Yeah.
Thanks, everyone.
Okay.
Thank
Right.
you.
Bye.
Bye.
Thank
Bye.
you. Bye.